You want to know what recurrent corneal erosion syndrome is? Okay, this is an eye. That's the cornea, and like most things in the human body, the cornea has layers. This outermost one is called the epithelium, and it's like the skin of the cornea. It's basically 5 or 6 layers of squamous cells sitting on a basement membrane. Now, since the epithelium is the part of the cornea that's exposed to the elements, the wind and the rain, it must adhere strongly to its basement membrane if it's going to survive. And it does this through hemidesmosomes and focal adhesions made of integrins bound to fibronectin, laminin and other integrin binding proteins. If this adhesion process goes wrong, you get what's known as recurrent corneal erosion syndrome. It's in the name. When the epithelium won't stick properly to the basement membrane, it keeps sloughing off, it keeps eroding, hence recurrent corneal erosion. This usually happens because of scar tissue forming on the basement membrane, a fibrocellular pannus that gets in the way and stops the epithelial cells from growing smoothly over the top. The resultant bumpy epithelium then sloughs off at the slightest inconvenience. As you might expect, the most common cause of this scarring is therefore trauma. And the most common culprit is a fingernail. Somebody, usually a child, pokes you in the eye, causing a corneal abrasion which heals in a few days. No big deal, right? Well, not until a few years later, when you start getting these occasional episodes of a red painful eye which seems to settle over the course of the day by itself. That's because your corneal epithelium is bumpy, keeps coming off, then tries to heal over, but can't stick properly. Rinse and repeat. And these episodes tend to be most common in the morning because the shearing force from the opening of the eyelids is really good at taking off that bumpy epithelium, but then it heals. The corneal epithelium is very proliferative. So, unless the patient comes in with a fresh corneal abrasion, you probably won't see much on examination. You might see negative staining with fluorescein, showing irregularities in the ocular surface. Another hallmark is the presence of subepithelial microcysts, although these can be very subtle and easy to miss if you don't look for them. That's why the history is so important, so make sure you ask your patient about eye trauma. Of course, there are other causes of recurrent corneal erosion syndrome. The second most common cause is a common hereditary condition called epithelial basement membrane dystrophy, usually abbreviated to EBMD. It's also called Cogan's microcytic dystrophy or map dot fingerprint dystrophy, because that's what you see on examination, opacity in the shape of map shapes, dots and fingerprints. EBMD is inherited in an autosomal dominant fashion, probably a mutation in the TGF-beta1 gene like most corneal dystrophies, which means it usually affects both eyes. Histologically, the problem is the growth of extra sheets of basement membrane. Epithelial cells migrate upwards through these extra sheets and become trapped, forming cysts that you see as dots and fingerprints. All of this naturally causes a problem with epithelial adherence, and is therefore a cause of recurrent corneal erosion syndrome. Although these people don't usually start having episodes until they reach their 30s. Can be younger, can be older. About 2/3 of people with EBMD never have any episodes at all. EBMD is weird like that. Other causes of recurrent corneal erosion syndrome include other rarer corneal dystrophies, which I won't go into, dry eyes, corneal surgery such as LASIK, ocular rosacea and diabetes. But the two commonest are trauma and EBMD, so those are the ones to remember. So, how do you treat recurrent corneal erosion syndrome? Well, if there's an active corneal abrasion, you'll already know how to deal with that. Abrasions are easy to treat. Bit of antibiotic to reduce the infection risk, bit of cycloplegic for pain relief, and a bit of hypertonic saline if there's any corneal edema. Heals on its own nicely within 24 to 48 hours. But what about recurrent corneal erosion with no active erosion? Obviously, you need to tell the patient to avoid rubbing their eyes. Then, the first thing to try is intensive lubrication. We're talking 2 hourly drops in a night ointment, at least. Maintaining the tear film is a good way to protect the corneal epithelium and prevent those erosion episodes. Another way to protect the epithelium is a bandage contact lens, that is, a protective contact lens with no focusing power. But it does lock the patient into coming back to clinic every 4 weeks or so to swap out the contact lens for a new one. It also means the patient needs to be on regular antibiotic drops to reduce the risk of an infection associated with the contact lenses. Other ways of increasing the tear film can be tried, such as punctal plugs. The majority of patients will be very happy now, but what about the few that continue to suffer? If none of these measures work, then you'll need to get to the root of the problem. You'll need to sort out the adherence, and that means surgery. There are 3 procedures to pick from. The first one is very rarely done these days, but I'll mention it anyway. It's called anterior stromal micropuncture. Basically, you get a needle, or even a YAG laser, and you make tiny punctures over the area of loose epithelium. This causes scar tissue to form, which increases adhesion and solves the problem. The main advantage of this procedure is that it's quick, easy, and you can do it in clinic. The main disadvantage is, well, the scarring. Practically, this means you only want to do it if you know exactly which area of the cornea is the problem and it happens to be in the periphery, because you really don't want to cause haze or scarring in the optical centre. So I've personally never seen this procedure done. Let's talk about the other two main surgical procedures then, alcohol delamination and phototherapeutic keratectomy. Alcohol delamination is very simple. You pour 18% alcohol on the cornea, leave it for 30 seconds, then wash it off. This loosens the epithelium, which you can then swipe it off, polishing that basement membrane until it's nice and clean. That's it. That's all there is to it. Then you put on a bandage contact lens, give them a few weeks worth of steroid and antibiotic drops, and see them in a week's time to remove that contact lens. Now, by removing the whole corneal epithelium this way, you basically give it a blank slate. You give it a chance to grow again. It grows back very quickly, and hopefully smoothly this time round. The success rate is about 75 to 90%. The other option is phototherapeutic keratectomy, usually abbreviated to PTK. In this procedure, you remove the corneal epithelium exactly as I've just described, but then you use an excimer laser to shave off the 5 to 10 microns of Bowman's layer, the layer below the epithelium basement membrane. So, if you didn't get rid of whatever was causing the adhesion problem before, you definitely did now. It also tends to remove any scarring, which improves visual acuity. Importantly, the success rate is basically the same as for alcohol delamination. The main disadvantage is the higher risk of corneal haze or scarring because the Bowman's layer is basically condensed corneal stroma, which doesn't proliferate. Unfortunately, stroma tends to scar instead. Which treatment you pick of these two depends on how deep you think the problem is and what facilities you have available to you in your particular hospital. If none of these procedures work though, there are other treatments. The favourite at the moment is autologous serum drops. Only certain centres do these. Basically, you take some of your patient's blood, centrifuge it to separate it into its components, and then you give their serum back to use as eye drops. The serum contains lots of growth factors which corneal epithelium loves. There are more experimental treatments on the horizon, such as matrix metalloproteinase inhibitors, but I won't go into those because I think I've told you enough for now. So if you've got any questions or any comments, please leave them down below, and please like and subscribe. Thanks for watching.